Welcome to the Ambulatory Healthcare Today podcast, hosted by the NextGen advisors. Accelerate your success with insights from a multidisciplinary team of healthcare experts as they discuss an array of topics. These timely discussions can help you better navigate the challenges of running your ambulatory care practice. Here is your host.
Hello, this is Dr. Marty Lustick, Senior Vice President and Principal with NextGen Advisors. With the recent ONC final rule related to interoperability from the Cures Act, there's been a lot of talk about this issue of interoperability. Today, we're going to take time to discuss the historical context, and we're going to do that by going back to the 1960s and discussing how information sharing has evolved over the past 60 years. To accomplish this, I'm joined today by my fellow NextGen advisor, Graham Brown, and NextGen's product manager for interoperability, Travis West. Welcome to you both.
Hey, Marty. Good to be with you.
Thank you.
Travis, since you're a newcomer to our podcast, can you take a minute and just tell us a little about yourself?
You bet. Yeah. Thank you, Dr. Lustick and Graham, for the time you've given me today. And for me, I've lived in Nashville, Tennessee with my lovely wife, Amber. And we've been raising our three boys for about the past 23 years. And most of that time, I've worked in healthcare as a IT product manager and program manager for healthcare startups and a couple of the largest healthcare organizations in the United States. Today, I've been privileged by working alongside with great business leaders and a development team at NextGen Healthcare, and excited about the topic of interoperability and Mirth Interop as part of our discussion.
Great. Thanks for sharing that, Travis. In a general sense, when people talk about interoperability, they're referring to the ease with which information can be shared. Can we start by looking back at the 60s and 70s? Travis, what did it look like back then?
What's been great about interoperability, and when we think about interoperability, most people's eyes start to glaze over, right? They start to get like, oh, what are we talking about? Even the term itself is a little boring. But I hope that you'll stick with me for a few minutes, because I think it's more interesting than you would expect and less ambiguous as it sounds. So interoperability really is about three things: infrastructure, and infrastructure are things like servers, networks, security, and end-user terminals. Number two is really around transformation. So what data is being shared, like demographic information or clinical information. And number three is semantics. So it's the agreed language that we exchange information on. So in the 60s, things like SNOMED, LOINC, and ICD had started to emerge. And you start to see, when you look at interoperability, that it did actually exist in the 60s. And there's a term that I actually had to look up, because we were starting to look at, well, how does interoperability fit in those days? And there's a term called reprography. Reprography is a term that is used to classify duplication. In healthcare, duplicating clinical and patient history was clearly needed to share information between a GP or a general practitioner and his or her medical counterparts in emergency medicine and surgery and in other circumstances that needed to be, information needed to be shared. So sharing information is a result of reproducing records, and a variety of methods to reproducing those records and duplicating those records were used in healthcare. And one of the most common ways, which most of us are aware of, is a carbon copy, which the medical record was triplicated using a technology that transferred from the top layer of a form to the second layer and typically to a third duplicate. And in the 60s, as I understand it, the transfer of patient information through these carbon copies made it possible for written records to be transferred to the hospital, to an internist, to a pediatrician, those types of physicians and care providers. And that was shared not only just with the clinical team, but also with office staff, billers, and other people that are needing that information at the time.
Thank you for sharing that, Travis. Before I talk a little bit about clinical care, it did strike me when you were describing carbon copies that a lot of our listeners may not realize that when they CC somebody on an email, that stands for carbon copy and refers back to the technology that you just described, primitive though it was.
And BCC stands for blind carbon copy,
Right.
So that the individual doesn't know that they're getting a copy sent to somebody else.
So let me talk a little bit about how that infrastructure met the needs at the time based on the way clinical care was delivered. And for me, this is close to home since I grew up in the household of a solo practitioner pediatrician. So I saw a lot of what went on up close. And I think, the major issue that differentiated the 60s and 70s from today clinically was complexity and the level of complexity. Both in terms of clinical, there wasn't as much, specialization was in its earlier stages then. So even as a pediatrician, my father was considered a specialist because there were so many general practitioners that only had a limited amount of pediatric training that he would be brought in to consult on pediatric cases by the general practitioners. So that's one thing that was simpler, but also the way practice was done clinically was very different. So as a solo practitioner, my father followed his patients no matter where they were. He saw them in the office. He saw them when he made house calls. If they had an emergency, there was no doctor in the emergency room. There was no emergency medicine physicians in most hospitals at that time. So he went to the emergency room, day or night to see his patients there. There was call coverage, but in general, the information was passed verbally about patients, when it's sign out in the evening and sign in the morning. And because there were so many fewer handoffs, the need to be able to transfer information and have it readily available was much less back then. And then on top of that, Graham, can you talk a little bit about how the regulatory environment and the business models were different back then?
Yes, indeed. Happy to. So, back in the 60s era, we didn't as yet until 1965 have the Medicare and Medicaid Acts. And so how care was paid for was often through just direct employer-sponsored insurance or directly out of pocket by patients who wanted to go see their doctor. They would pay as they go. And the physicians managed how payment was received and had to follow up with their patients. This is still the era when people got, loaves of bread instead of dollars for services that they provided. So, there was a fair bit of activity from the government level, expansion in science and new research. Technology was evolving, certainly a very politically active time. And so there's a fair bit of influence in that regard from that simpler clinical model to it getting more and more complex through the end of the 60s. The HMO Act was passed in 1973, which created a whole new role for payers that we see today to enter in as intermediaries in the flow of dollars from those that purchased insurance, whether it was an employer or an individual directly, to the providers who got paid. And that added a huge amount of codification to how care was provided, how care was documented, and how care was paid for. So think just about, going to see your physician in the 60s, and the doctor might have checked 5 different things for you. And they wrote a little note in the record, and they shared that record, as Travis was saying, in a carbon copy with people who needed to see it. 10 years later, that needed to be entered as a procedure code, a diagnosis code. It needed to be billed in a certain way. So that one activity correlated to 3 new technology events. And we needed to start capturing that information and sharing that information in a new way. Some of those systems and tools then that we're developing at the same time concurrently weren't yet being applied to healthcare, but we had the development of the fax machine. We had mainframe computers, and these were starting to kind of surround the healthcare ecosystem. And so as we moved and transitioned from paper and pencil to telephones that were pretty effective and efficient, by the end of that period, we see, as you were saying, Marty, that rapid expansion of specialties and subspecialties, more government programs, payment models, and intermediaries acting to move information in a new way between the various different partners. So everything just started getting incrementally more and more and more complex.
That's a really good summary of that period, Graham. Thank you. Why don't we jump forward now to the turn of the century, what we lovingly referred to back then as Y2K. And this time we'll start with you, Graham, in the regulatory and business environment. What's really noteworthy from that period from your perspective?
So a couple things I'll highlight. The first happened just before the turn of the century, and that was HIPAA. So that was passed in 1996, and by the turn of century was really being actively implemented. So provider organizations were really paying attention to how they needed to protect and secure personal health information. A lot of new definitions around what was personal health information, who had access to it, and how it needed to be controlled. As computers were coming into broad use across all businesses in the 90s, right? We have the internet starting, we have Google starting in the early 90s. For those of us old enough to remember, Y2K was this seminal event that everyone was terrified the entire world was going to shut down because we had all this reliance on computerized systems for managing telephones, for managing power, for managing, our utilities and all of these systems that we rely on as a society. And much of the concern was around how date information was codified. Up until that point in time, we used a 2-digit date increment for the year. So 99 meant 1999. And there was an enormous effort to kind of reprogram things so that the world didn't shut down when the year hit 2000. And as we know, chaos didn't ensue, and we all survived all of that. From a healthcare financing perspective, the late 90s also brought, these HMOs that were set up in 73, they started moving into risk arrangements with providers, and we're doing capitated risk. They took on a lot of risk, but they didn't have the tools and systems we have today to understand what was quality care. What was utilization? Who was using services and who wasn't? And what were the outcomes that were being achieved by the care that was being provided? So HMOs took a huge amount of risk on and kind of got burned. They ended up going bankrupt, many of them. There was a lot of consolidation. If we fast forward a little bit just past the turn of the century, then all of those failures within the financing schema laid the foundation for the Affordable Care Act, which passed in 2010. And a couple things about the Affordable Care Act. It really dramatically expanded insurance access. That was one of its primary goals. Remember, in 2009, there were 43.6 million uninsured citizens in the United States. It was a huge issue of medical bankruptcy. People didn't have access to care. It was really unaffordable. So the ACA passed, but it also did some other things. It created health insurance exchanges. It expanded Medicaid access across the United States. So a number of people became eligible through Medicaid directly or through insurance exchanges. But it also set up things like the Centers for Medicare and Medicaid Innovation, which started to test alternative payment models, different delivery structures, and helped us really kind of move into different models of integrated care. Marty, talk a little bit about what was happening through that period in the status of clinical care, because it was evolving just as rapidly.
Yes, absolutely it was. And, we really see, if we think back to what I described as in the 60s and 70s, just a quantum leap in the number of handoffs that occurred by the turn of the century. By the turn of the century, it was routine for emergency rooms to be all staffed by ED docs. And within the hospital, you had early hospitalist programs. You had intensivists in the intensive care unit, neonatologists in the delivery room, and in the nurseries. So that both specialization and the beginning of things like more shift work among doctors, where ED doctors are a good example. They didn't work 24 hours a day like their predecessors. They worked 8-hour shifts or 12-hour shifts. And so there were many more handoffs clinically. In addition to that, the healthcare team was growing larger and more complex, not only because there was more subspecialization, but by the turn of the century, nurse practitioners and PAs were in routine use in most parts of the country. Interestingly, at that point, as opposed to today, they were almost all in an employed status at that point, where they were functioning largely as what we described as physician extenders. But it was a substantial expansion of the team, which again creates more complexity, more handoffs in the clinical care process, which of course has implications for what information needs to be shared, how, when, and with whom. So I think those are some of the critical things. When I think about it in terms of the use of technology, and I know from my own experience, I was seeing patients at that time, the turn of the century was interesting because many physicians, or a significant number, had PCs on their desk by the turn of the century. And some of them had EMRs, but it was pretty sporadic across the country. Many of them were homegrown. Some of them developed by physicians who then, tried to sell them to other docs in their community. It was really kind of a mom and pop kind of industry in many ways. And at the same time, we were totally dependent on paper charts, even where we had computers. We would use the computers, but we couldn't really. We were in this transition phase where it seemed like we couldn't get by in a day without having both our paper chart and our computer available to us. So Travis, can you help us understand a little better from that technology perspective? Where were we with interoperability right at Y2K?
100%. And I think kind of leading up to that, let's tell a little more backstory earlier in the 1980s and 90s, where you started to see some hospitals, healthcare associations like the American Medical Association, and maybe even large universities with medical programs instituting computer systems in the walls of their organizations. And you start to see how information is managed in a variety of ways. So, hospital A versus hospital B would slightly change the way in which they use those systems in order to provide care, the way they would bill, the different types of utility that the technology would serve that particular organization. And at the same time, in a different parallel, communities started to be interested in exchanging data. And so you started to see the emergence of RHIOs, RHIOs, or Regional Health Information Organizations. And Rochester, New York is one of the first places that took place. And you start to see a host of these sort of medical devices emerging also into healthcare a little bit. I went back and had to look, but a pulse oximeter, an external defibrillator, the first large-scale PACS system started to be introduced in the 80s. And you start to see just this emergence of technology coming into the medical space. And so how do you integrate the information coming from those systems into a paper chart or into an electronic record? I mean, there are just a lot of emerging technologies and new medical specialties and scientific research that's all blending into this space starting in the 1980s. And it's an interesting space to be, where nobody really knew how to respond, right? So that's where you do kind of see doctors saying, I think I could figure this out on my own. And so they go and take a computer science class, and they start to, they start to develop. And I met some of these gentlemen as I, started to work myself as the turn of the century came across, and you started to talk to them, and they said, we just couldn't get the answer, so I just decided to do it on my own. And so you can't, you can see that from the 80s, as you start to move into the 90s, the idea of electronic medical records had been established. Like that was happening in the hospital. It was happening a little bit in these large private practices. And little by little, we have an ever-increasing demand for information. And so what do you do with that information? Well, that spurs more conversation around policy, the direction that you should take that information, and the electronic record itself needing to transfer from a hospital to a private practice, to a laboratory, and other places where how do you actually get that information electronically from A to B to C? And that's sort of the emergence of a clear need for interoperability to exist with these electronic systems, where before interoperability was you put it on the fax machine, you put it in the truck and drive it over to the hospital, right? And that's just how it happened. In the early 80s as well, there's this new concept outside of healthcare about sharing data, like document sharing, news, online help. These types of things started to emerge in the minds of other organizations outside of healthcare and using technology to enable that to happen. And later, we will learn those improvements and collaborations is really the start of what we now call the internet, which launched in August of 1991. And so as we move into the 90s, as we all know, computers started to become an integral part of private practice. It became a part of the healthcare systems. They became commonplace in the workplace. There was, again, more technology that was being introduced as part of the care of a patient. And you can imagine the transition of medical care, technology, and scientific advantages. They rarely gelled together, right? They're running in different silos and different parallels all at the same time. And so it took a lot of effort by the government, institutions, and a lot of smart people to try to figure out how to get them all to work together. And a byproduct of those is interoperability. We'll continue to wrestle through the inconsistencies, gaps in the exchange of information and understanding how to manage that. So when we're thinking about moving into like the new century, the more and more we see the internet coming to the forefront, and you start to get into this space called consumer-based products. You want to have it on cell phones had been introduced. Smartphones are starting to kind of emerge. I don't know if you guys used the BlackBerry, but I loved the BlackBerry when that was around. And so how do you start to exchange a little bits of information? How do you text people? How do you send messages? And so as the turn of the century started to take place, we see the evolution of both the technology, but also the use of technology in the hospital and private practice.
Thanks for sharing. That was really interesting. And it feels like this period around the turn of the century was really a clear milestone, turning point, and transition in the way technology was embedded in healthcare. And even though we were dependent on both, it finally became clear where we were actually headed. I think that's about all we have time for today. So I'm going to thank Travis, you for being our guest today, and Graham for sharing your insights. We're going to follow up with our next podcast to talk about the same topic, but moving into the 21st century, kind of the last 20 years, and also looking forward. So stay tuned for the next episode. But thank you for joining us today, and have a great day.
Thanks for listening to the Ambulatory Healthcare Today podcast, hosted by the NextGen Advisors. Never miss an episode by subscribing at nextgen.com/podcast. To see a list of products and services tailored for ambulatory care practices, visit nextgen.com.